So imagine you've got a disease somewhere in your body, let's say a tumor, and you take a drug for it. With normal drug delivery, we basically blast the entire body with that medicine and just hope enough of it eventually finds its way to the tumor. Most of it ends up hitting healthy tissue in the process, which is why we get side effects. But we now have a smarter strategy: targeted drug delivery. Instead of sending the drug everywhere, we send it only where it's needed. We can direct medicine to a specific organ, a specific tissue, and in some cases, even specific types of cells. This idea isn't new. Scientist Paul Ehrlich actually proposed the idea of a magic bullet over a century ago, a medication that would seek out the disease and spare everything else. We're finally at a point where that vision is turning into reality. The whole point of targeted drug delivery is simple: more drugs to the problem site, less drug everywhere else. That means we can get both better therapeutic effects, but also use lower doses, have fewer side effects, and maintain more consistent drug levels over time. It's a huge step forward towards making treatment not just effective, but also more humane. There are three main approaches we use. They're called passive, active, and physical. Passive targeting uses something called the EPR effect, enhanced permeability and retention. It sounds quite fancy, but the idea is actually quite simple. Tumors tend to grow blood vessels very quickly, and those vessels are structurally sloppy. They're leaky. If we use really tiny drug carriers like nanoparticles, they can slip through those leaky vessels and build up in the tumor more than in healthy tissue. So passive targeting is kind of like taking advantage of a biological design flaw in cancer. Active targeting is where we get more intentional. We attach certain molecules to be the drug carrier that act kind of like a homing system. These ligands might be antibodies, peptides, aptamers, certain sugars, or even growth factors. Many cancer cells have extra receptors in their surface, like more docking stations than healthy cells. The ligands recognize those receptors, latch on, and let the drug enter the cancer cell more effectively. It's like giving the drug a GPS, so instead of just wandering around the bloodstream attaching to anything, they only go where they're engineered to be. And the coolest category is physical targeting. We can guide or activate drugs using physical forces, such as magnets, ultrasound, heat, or even light. For example, we can load drugs into magnetic nanoparticles and steer them with a magnet. Or we can activate the drug only when a certain wavelength of light hits it. It's like remote controlling the therapy from outside the body. Targeted drug delivery is already a major game changer in cancer therapy, especially compared to traditional chemotherapy. Instead of harming fast-growing cells everywhere, hair follicles, gut lining, bone marrow, we concentrate the drug inside the tumor. Patients can handle treatment better, and the quality of life during therapy improves dramatically. In cancer treatment, nanoparticles and liposomes are widely used to improve chemotherapy. For example, liposomal doxorubicin reduces cardiac toxicity because the drug accumulates in tumors rather than the heart. The 2023 review by Lee and colleagues highlights how nanocarriers are used in oncotherapy. They describe how nanoparticles can accumulate in tumors through passive targeting and how active targeting uses ligands to bind directly to cancer cells. Some systems can even deliver combination treatments like chemotherapy paired with photothermal therapy. We're also using these approaches for gene therapies, autoimmune diseases, neurological disorders, and more. It opens the door to delivering complex drugs like RNA-based medicines that would never work through normal delivery pathways. However, there are still real challenges. Every tumor is different, biological variability makes targeting unpredictable, and the immune system may sometimes clear the nanoparticles very quickly. Immune clearance is a major concern, and manufacturing these carriers is often expensive and technically demanding. Another issue restricts the wide use of these processes. Some tissues don't have clear targetable markers, making them difficult to design around. Targeted delivery also suffers the same issues that nearly all other new medicines also face. Moving new delivery systems through clinical trials is slow and costly. So while the technology is brilliant, we're still figuring out the best ways to apply it consistently for everyone. The key takeaways are, instead of treating the whole body when only one part needs help, Targeted drug delivery makes treatment more precise, more efficient, and less brutal on the patient. It's one of the most promising directions in modern therapeutics, and each year we get closer to a truly personalized, highly selective medical treatment, the kind Paul Ehrlich envisioned way back then.